Good evening, everyone. My name's David. Welcome to another one of ACPP's webinars and a continuation of a regular set of PD opportunities that the college will be running. Before we begin, I'd like to acknowledge the traditional custodians of the lands where my Australian-based colleagues are located today and pay my respects to their elders past, present and emerging, for they hold the memories, traditions, cultures and hopes of Aboriginal and Torres Strait Islander people of Australia. In recognition that we are a binational college, I take this opportunity to acknowledge the Maori as Tangata Whanoa and the Treaty of Waitangi partners in Aotearoa, New Zealand. This evening, I have the great pleasure to introduce you to our guest speaker, Ben Scamacia. Ben is an experienced mental health nurse of 10 plus years and is currently completing his nurse practitioner's masters through Western Sydney University. Through his extensive experience looking after patients suffering from mental health illness, Ben has now found himself working full-time with the Queensland Ambulance Service as a mental health clinician alongside their senior Lauru paramedics. Ben has a passion for education and mental health care and jumped at the opportunity when I gave him a call to discuss mental health risk assessment, and I wanted to thank him a lot for being here today. At the end of the presentation, there will be a short Q&A. If you have any questions, please feel free to write them into the comments section and I'll go through them in the order that they appear at the end. So without anything further, I'd like to pass the webinar on to Ben. Thanks, Ben.
Thank you. Okay, guys, how are you all this evening? Thank you, Dave, for the lovely presentation, lovely introduction. Today, I'm here to do a bit of a presentation of what risk is from a mental health perspective. I appreciate Dave giving me an introduction. So I've been working as a mental health nurse since the last 10 years. I've worked both in the private and the public sector in inpatient and community settings, mainly in Queensland. The role I'm working at the moment is going out with an ambulance officer, where we will attend to 000 calls and do mental health assessments on scene to try and determine the best care pathways, with the view of being able to either support people engage in treatment in their home and refer to local community services, or try and expedite their pathway through the hospital system and navigating that. Today's presentation is a look of a risk assessment as a component of a mental health assessment. I think what I would be suggesting today is that whilst I'm going to try and supply you guys some of the tools I utilize in my assessments when I'm working with my patients, that you do work within your local workplaces, policies and procedures. I will give you a heads up today. We'll be talking about some triggering topics such as suicide and homicide, which could be distressing. If it's something that is making you feel distressed, I put Lifeline's phone number up there, as well as Beyond Blue, and would recommend you contact your local crisis service, or you can exit the webinar if that makes you feel more comfortable. So I think I'd like to sort of talk about what is a mental health assessment if we're talking about a risk assessment. So a mental health assessment is the process of examining a person's mental state using a biopsychosocial and spiritual approach. That is quite a mouthful, but basically what this approach is, it's looking at a person from all spheres of their life. It's taking into consideration their biological health and biological needs, their psychological health and needs, social and spiritual. This includes the consideration of the precipitating and perpetuating factors for why we might be in contact with a person who's experiencing mental ill health or crisis or behavioral disturbance. So the precipitating factor is that triggering or catalyst factor that's led to the contact with them. And the perpetuating factors being more what's exacerbating this, what's making it continue, what's making it worse, those sorts of things. The mental health assessment also includes the MSE, which I'm sure we're all well versed in. That's taking into consideration things like someone's appearance and behavior. What do they look like? How are they acting? Are they engaging in the assessment? Have you got a good rapport with the person? Their speech, the rate of their speech, the tone of their speech, volume, is it making sense? Is it logical and coherent? Their mood and affect, which is really important. So when looking at mood and affect, we're considering what the person's subjective opinion is, so what their beliefs are on their current mood, and comparing that to your objective sort of assessment and observations as to what you believe their mood is, and their affect. So how is their actual facial features and their responses to conversation appearing compared to what you're assessing and what you're seeing. So is it congruent? Is it incongruent? Have they got no expression? All those sorts of things. And then once we're sort of moved past mood and appearance, we're considering any perceptual disturbances. So, is this person experiencing any auditory or visual hallucinations, tactile hallucinations? Have they got distortions of reality? Are they, seeing a stick on the ground and are they interpreting that as, a message from a higher power telling them what to do and try and guide them on their pathway? The next sort of component of that is thought form, thought stream. So have they got any disruptions to their thought process? Is it logical? Is it coherent? Or is it, disorganized and all over the shop, not making any sense at all? Following this is thought content. So what is the actual themes of the conversation? Imagine this is the flavors of your cake, Are they paranoid? Are they grandiose? Are they delusional? Are they suicidal? Are they homicidal? That sort of component of things. Then once we've sort of looked at thought content, we start considering someone's insight and judgment. Do they recognize that something's amiss at this point in time? Do they acknowledge that they may have a mental illness or might be experiencing mental ill health? Do they have judgment attack? Are they help seeking? Are they making sensible decisions? Are they sort of trying to mitigate the scenario around them? Insight and judgment also makes up sort of the proportion of considering someone's capacity. So capacity is someone's ability to make informed decisions about their healthcare. Do they recognize kind of mental illness? Are they sort of openly seeking treatment? And if they're not, are they able to weigh up the pros and cons of treatment? Those sorts of things. And the final component is cognition. That's a little bit harder, normally done through more formal assessments, but as a person alert and orientated, are they potentially experiencing any intellectual impairments, whether that be through a neurodevelopmental disorder or an intellectual impairment or dementia or Alzheimer's, those sorts of things. So that's your MSE. And then a really important part of your mental state examination is taking into account what sort of history you can get. So this might be the person's reported mental health history. So the information they're giving you, it might be collateral that you've gathered from their GP, psychologist, their mental health service, or their supports around them or their loved ones. History is a really important component of this. It's sort of establishing what a person's longitudinal baseline is and comparing, okay, if this person's had a long history of mental illness, how can we compare them now to how they are across their lifetime? And sort of the final component of doing a mental health assessment is to try and rule out what might be the etiology for the person's presentation. So I think it's really important to sort of discern between mental illness and biological disruptions. So an example that I have come across in my practice is, for a presentation for an 83-year-old male who's got no mental health history, who's, experiencing paranoid ideas that people are robbing his house. He may have hallucinations that insects are calling up him, or he's hearing voices, but, he's also got malodorous urine and he's running a temp of 38. When you're hearing that, you're starting to think, this may not be a mental illness. This could be a delirium secondary to an underlying infection or organic sort of deterioration, those sorts of things. So that's sort of very simplified version of what your mental health assessment is. So your risk assessment is a component of your mental health assessment. It's not necessarily separate assessments. The two work at the same time. So the dictionary says risk is the possibility of loss or injury or someone or something that creates or suggests a hazard. For us, the consumers, which is the mental health clients and the health service, risk refers to the probability of an adverse event or experience, or more specifically, clinical risk relates to the probability of a beneficial or adverse outcome as a direct result of the changes caused by the person's mental illness or external factors or intoxication or whatever might be sort of precipitating their current presentation. A risk assessment is the process of trying to explore and determine the potential benefits or adverse outcomes to an individual as a result of an event or stimulus. The idea of doing your risk assessment is to minimize the potential for negative outcomes and maximize the beneficial outcomes. When we look at risk assessment, it sort of comes in three very broad domains, and that's risk to self, risk to others, and risk from others. As professionals, the reason why we want to determine what's happening in these situations and do our risk assessments is to ensure that the person we're working with who's experiencing this mental illness or ill health or crises or behavioral disturbance, we want to make sure that they are safe and have the opportunity to access help that's appropriate to their needs at that time. Where possible, we want to minimize adverse outcomes and promote positive outcomes, which is utilizing that information we've garnered from our risk assessment. When looking at risk, I think it's really important to look at it from these sort of three factors, so the first factor being static factors. So these are the historical or fixed or enduring factors that are with a person across their lifetime. This might be age, gender, ethnicity, exposure to trauma in childhood, those sorts of things that can't be changed, or they're not easily changed. They're going to be with them for a long time. The dynamic factors, these tend to be more malleable and relate to the current risk state, what's happening in the current moment. That's sort of what's perpetuating the crisis, what's precipitated it, what's happening during your assessment with them. These are the factors that are more malleable, more easy to be changed, both for negative and positive. And protective factors, these are things that sort of mitigate or reduce the risk. These can be personal factors, things like a person's attitudes and values, hope for the future, good coping abilities and ability to deal with stress and negative emotions, or it could be environmental or external protective factors. These are things like supportive relationships, social connectivity, a safe and stable environment at home, those sorts of things. The risk domain, so we touched on this a little bit earlier. This is sort of where we're broadly looking at risk in our mental health assessment. So, the first one being risk to self. This is things like suicide and self-harm. Risk to others. This is things like aggression and homicide. And risk from others. So this is things like a person's vulnerability, their risk of being exploited, domestic violence, risk to reputation, those sorts of things. This is not necessarily an encompassing risk of all risks we need to be mindful of. This is more just what I'm going to focus on talking about today. When we are working with these vulnerable populations of people, we need to be considering things like, child safety, domestic violence, elder abuse, and whatever other risks really sort of come to mind when you're working with someone. So I'm going to start with talking about some suicide statistics, which are going to form the basis for some of our static factors when considering risk for suicide. So, suicide is the action in which someone intentionally takes their own life. In 2020, in Australia, over 3,000 people lost their life to suicide. Over 2/3 of these were male. It's currently the leading cause of death for people aged between 15 and 44. The suicide risk amongst Aboriginal and Torres Strait Islander peoples is twice as high as non-Indigenous Australians. And people who have a history of mental illness or mental anguish, have previous suicide attempts, have been exposed to suicide, or have a history of substance use, are also at a much higher risk of suicide. So those statistics are quite confronting in and alone of themselves, but these are the factors we're taking into consideration when we're determining our static risk factors. Is the person we're working with, are they male? Are they, aged between 15 and 44? Do they have a mental health history? Have they either had previous suicide attempts themselves, or have they lost someone to suicide, or found someone who's ended their life from suicide? Again, these are the enduring factors that are difficult or we can't change. So, as those static factors are starting to add up, you're starting to consider, this person's long-term risk appears to be quite elevated. So these static factors are what determine our longitudinal risk. So this is sort of where we're starting to paint a picture as, what is this person's risk like across their lifetime? Dynamic factors are focused on the current presentation, what's happening in the here and now with this person's suicidality. So assessing, dynamic risks of suicide is looking at things of the person's suicidal thoughts. So what sort of thoughts of suicide are they having? What's the intensity of these thoughts? Are they intrusive? Have they got no control over them at all? Or is it a fleeting thought that pops in every now and then? what is the frequency like? Is this something that's happening every day? You know, is it taking up 50, 60, 70, 80% of their day? So the suicidal thoughts is sort of the intensity and frequency these thoughts are occurring. And then planning. Have they taken careful consideration about how they're going to end their life? You know, have they completed a will? Have they, you know, started saying goodbye to people? Have they written suicide notes? Have they been researching, you know, ways in which to end their life and discovered a means that best suits them? Which sort of leads us in our next component, you know, do they have access to means? So if this person is really considering how they're going to end their life, for example, they're talking about wanting to use a firearm on themselves, access to means is how readily available is that choice of suicide available to that person. So if it's a firearm, do they have a firearms license? Do they have a firearm in their home? Do they know how to use a firearm? Or do they have access to a firearm through friends and family? Intent is related to how determined is this person to end their life. This is those, you know, is a person telling you, you know, I'm done. There's nothing in my life that's protecting me. I'm ready to go. And, you know, you're noticing a high intensity, a high frequency of suicidal thoughts. You know, they've got a really considered plan of how they're going to end their life and they've got access to means. You know, are they trying to hide or get away from you or try and be guarded about the information? If you're seeing those sorts of things, you're starting to think, wow, this person's intent is quite high on the consideration if they want to end their life. Moving into protective factors, again, these can be static and dynamic, and they can be internal or external. So internal factors will tend to be a person's, you know, ability to cope with stress and distress, or their mental illness. Their religious beliefs, you know, certain religions will forbid suicide. Hope for the future. Does this person, you know, have things they're looking forward to in both their immediate and distant future? You know, they're telling you they've got a date in 2 days with someone they've been in love with their whole life and they're very excited about it. And, you know, they've got a job promotion coming in 6 months they really want to do. Or is this a person telling you they've got no hope for the future at all? And one of my favorites is a personal framework for meaning. So does this person have purpose in their life? Are they someone who is a mother, a father, brother, sister, and relish in their role? Or are they an academic and they really enjoy, you know, engaging and teaching and those sorts of things? Or are they someone who you know, they've recently been through a divorce and they've lost their role as a husband or a parent, or, you know, they've lost their job and lost their meaning for what they're doing in their life. External factors include things like support from their family, friends. Pets is a great one. Responsibilities and duties, you know, did this person have work or engagements or kids or something like that they have to attend to? And restricted access to means. So sort of what we were talking about before, that they don't necessarily have access to whatever their elected means to end their life might be. I've sort of created a separate slide for self-harm because it is a very unique situation that we're faced with in our roles as health professionals. Self-harm is a term that's used when people are engaging in intentional self-harm to hurt themselves. Some common means of self-harm are things like cutting, burning, overdoses, interfering with wound healings, hitting self, choking self, a variety of means. It's a really complex behavior that there is no black and white way to assess it or manage it or address it. You know, that there's a group of people that have used self-harm across their lifetimes as a means to cope with emotions. You know, it's their way, it's their version of going for a run or talking to their friends or painting or expressing themselves. And for other people, you know, they're engaging in self-harm as a means of expression of their suicidal thoughts. Really, you're using quite similar techniques to when you're determining suicide risk as when you're assessing self-harm. You know, is this been a long-term behavior for someone, whether engaging in superficial self-harm, or is this as Joe Blow, who's got no previous history, who's engaged in cutting himself with a laceration so deep it's going to require a surgical clean out and repair. You know, it's about determining what's happening in that moment. Moving into risk and others, this is an area that's a little bit of a bugbear for me, and it always makes me sad when you see broadcasted on, you know, mainstream news that, you know, the person who has a mental illness is you know, engaged in a violent act. it creates stigma, it creates fear. It's unnecessary. Like a very common and easy accessible statistic is that 1 in 3 people across their lifetime will experience symptoms of a mental illness. If we're using what can be portrayed on the media or stigma suggests, and we're sort of saying 1 in 3 people are at risk of hurting others, which isn't a reality. In fact, majority of the people who are receiving treatment in the community and living in the community are at no different risk from anyone else, from myself or from you guys or anyone else living in the community. What is important is to recognize that risk of aggression and violence is something that needs to be taken in consideration with mental illness, especially if someone might be psychotic or have a history of previous aggressive or violent behavior, or they may have a personality disorder where they struggle to cope with their emotions or can be quite vindictive towards others. It's a very complex relationship, one between aggression and mental illness, and whilst it's important to consider, I don't think should always be considered a direct correlation. Mental illness results in aggression or violence. I'm not a forensic psychologist, so the risk screening I'm doing is from a consideration of a mental health perspective, but there are tools that psychologists and other professionals will use to determine risk to others. So much like suicide, static factors of homicide or aggression include things like a history of substance misuse, history of psychotic illnesses, things like schizophrenia or drug-induced psychosis or bipolar with a psychotic component, those sorts of things. The history of violent offending behavior. So if the person's got a history of domestic violence or assault or, possession with intent of carrying a weapon, those sorts of things. I'm not saying that a person can't change, because they most definitely can, but often the number one indicating factor for repeat violent offending behavior if someone's got a history of it. Age, gender, typically males do tend to be at higher risk of aggression. Histories of suicide attempt and assault impulsive behavior. Whilst there's not necessarily a correlation between a suicide attempt and someone being aggressive, often suicide attempts and impulsive behavior are indicative of people who've got, struggle to manage or cope with their emotions or things that are difficult. So it might be also hard for them to control their ability to contain their anger, and they might express it outwardsly. This is not necessarily an exhaustive list, but it's just some ideas of what some enduring risk factors can be. Dynamic risks, much like when we were talking about with suicide, these are your current thoughts, plan, and intent to cause harm. Is this person having regular thoughts to hurt others? Is it occurring daily? Do they have access to means? Have they been considering how they're going to do it? Are they wanting to do it? Are they telling you, yep, you let me go, I'm going to go and knock off Joe Blow down the street, those sorts of things. I've talked about access to means. So if they're saying they want to go and knock off their neighbor and they're going to do it with a hammer, and then they've got the hammer on the desk ready to rock and roll, you're starting to think, oof, that person means business. Had there been any recent aggressive or violent behavior? Are they intoxicated or under the effects of drugs and alcohol? Often a lot of the violence or aggression that can be seen in emergency setting or in a mental setting can be perpetuated by someone who's intoxicated or maybe experiencing an adverse effect to substance use. One of the really important ones that I would like to talk about today is psychotic processes. So sometimes if someone is experiencing a psychotic episode, that the processes involved in that can be driving them towards aggression. So that could be things like delusions of being paranoid. Does this person think a gang might be after them? Are they arming themselves, worried that someone's going to hurt them or their family? Do they have an erotomanic delusion, which is where they believe someone's in love with them, but it's delusional, it's not true? So you can come across someone who might believe their neighbor, they need to, marry them and that they're in love, they've been in love for years, and the only way they can be together is by knocking off their neighbor's partner. Is it a hyper-religious delusion? Is this a person that believes that receiving messages from a higher power where they may have to cause harm on a minority group or a particular ethnicity or, a sex or gender, those sorts of things? And as a component of that is this the person experiencing auditory hallucinations? So, hallucinations can come in a variety of means. They can be commentary, which is, chatter away. They can be derogatory, which is being cruel to the person, or they can be command. So command is when the voices are telling someone to do something. And it's really important to take these into consideration if someone tells you they're hearing voices, because imagine, this person might be hearing, 5, 10, 20, a variety of voices talking to them. And if they're telling them to do something and it's occurring multiple times through the day, it's a very difficult thing to deal with. And sometimes these command voices can't become like quite aggressive. People will, experience these hallucinations to go and do something to someone, and the voices say to them, if you don't, I'm going to hurt your family or your mum or your pet. So it sort of adds to the distress associated with that. Ideas of reference or receiving messages. Is this person sort of receiving information from their TV or telephone or the radio that's sort of encouraging them to go and engage in violent acts? And finally, is this person scared? And this goes back to that whole fight or flight sort of concept. If someone's backed into a corner and they may be psychotic or they may be, very distressed, they're going to do what's necessary to protect themselves. Again, sort of when you're looking at static and dynamic risk factors, a lot of these can sort of correlate between suicide and homicide. So you should be taking in consideration when assessing suicide risk. Is the person paranoid? Is a person experiencing command hallucinations? Do they have ideas of reference? Because these can all be quite distressing. Protective factors when it comes to risks to others is things like, internal factors. Is this person intelligent? Do they have a good ability to cope with their emotions? Do they have good self-control? Are they help-seeking? Do they want change? Are they motivated to engage in change? Is there a desire there to cause harm, or was it an off-the-cuff expression in distress? Those sorts of things. External factors could be, is the person linked with supportive services? So, for example, if it's a person who might be a domestic violent offender, are they going to probation and parole? Are they engaged in day programs to try and manage, their more challenging behaviours? They have friends and family that are supportive of them. If it's someone who has an enduring mental illness, are they linked in with a community team? Are they seen regularly? Are they taking their medications, helping sort of reduce their psychotic symptoms, those sorts of things. And vulnerability, this is one that I sometimes think goes by the way, just because it's not as broadcasted as violence or suicide or those sorts of things. So this is things like, is the person we're seeing, are they at risk of exploitation? Or is this a manic person that's going out and spending all their money and easily manipulated by people? Are they someone who might be psychotic and, part of their psychosis is including their neighbor? And so they're going over their neighbor's house and throwing rocks through the windows and, putting horrible letters in their letterbox. So they at risk of damaging their reputation. Risk of misadventures is a person who's paranoid and they're driving their car around. They think people are following them, so they're trying to dodge them on the road. They're making sort of poor decisions that way. Is the person at further risk of deteriorating either mentally or physically? So the example I like to use is the acutely depressed person. So someone can be depressed and not necessarily be suicidal or psychotic or homicidal, but they might have been in bed for a week and they're not going to work, they're not engaging in their relationship, they're not eating or caring for themselves. So in that situation, whilst they may not be necessarily suicidal or homicidal, you're starting to think, if treatment's not engaged here, is this person at significant risk of deteriorating physically or mentally if it's left to continue? And ongoing out is, sexual disinhibition, self-neglect, impaired decision-making, and that sort of steps into capacity. Does the person making, sensible decisions about their health and their life and those sorts of things? So vulnerability is quite an important one. And, protective factors with this is, are they help seeking? Do they have supportive family? Are they linked in with supportive services? Similar sort of things that we've talked to throughout our other risk screenings. I think something I really wanted to hammer home today is that your risk screening is not a standalone tool. It's something that's done in conjunction with your mental health assessment. It's sort of what you're determining about the person's current mental state is really going to influence what you're determining about their current risk state as well. There is no one formula or tool that's going to encompass all these aspects of risk. It's just about engaging and reading and learning and trying to upskill yourself using different questioning techniques or ideas to determine risk. So I'd just like to say thank you so much, guys, for listening. I know I've blabbered on for a little bit. I'll hand it back to Dave now if there's any time for questions. So thank you all.
Thank you very much, Ben. I'm not sure if you guys can see me. I can't see myself on the screen at the moment. Guys, do you have any questions at all for Ben. That was a really interesting topic. Thank you very much, mate.
No problem at all.
While we're getting some people to think up some ideas, I just have a question regarding access and care for patients. So we had a paramedic working in a community in any sort of setting, whether it's ambulance or in a primary care setting, and you had concerns, let's say that they weren't necessarily actively suicidal, but they were showing some of those risk factors that you've outlined, and you are a bit concerned about them and where they might be in the coming days and weeks. What are some easily accessible or regular services that might be available to people around Australia and New Zealand? I know that they may change a little bit between states, but where would be a good starting point to reach out for care if you've just got a concern about the long-term or medium-term mental health of a patient who you're looking after?
Most definitely. Well, unfortunately, my knowledge with other services across Australia is limited. I know that places like Victoria and Queensland and New South Wales do have a similar system to Queensland, in that there is a link between their local crisis services. So on the Gold Coast, this is all the Queensland really, it's the acute care team. So I'd sort of be saying, if the person on scene working with someone who's in distress is worried about them and has come to sort of a bit of an end, to contact your local crisis mental health team and sort of reach out to them for some advice, trying to link the patient in with supports, those sorts of things. I also think if you've got the patient's consent, you're trying to reach out to, if they've got a personal psychologist or psychiatrist, see if you can get access to that information. But yeah, in Queensland, what I'm starting to notice on the Gold Coast is that our paramedics here are much more judicious in their use of contacting our acute care team and crisis team and saying, hey, look, I'm here with Joe Blow. Are you able to, help me out and do a bit of an assessment with them, or give me any recommendations, those sorts of things. So that would be my suggestion, would be, trying to link in with your local crisis mental health service and trying to develop a relationship with them. And try and link in with the person's sort of primary care supports, their psychologists, psychiatrists, those sorts of things.
Yeah, that's really interesting. And I guess in the setting where somebody does not have any of those inputs already, they're not linked with the acute care team, I guess linking in with general practitioners is a good starting point as well. Of course, we've always got the emergency department for those high-risk presentations and concerns, and that would obviously, in my opinion, would lead to further input and support services engaged. But in your experience, do you engage much, or have you engaged much with general practitioners seeking help as well? So being able to have a paramedic say, I've got some concerns about someone who I feel may have some depression, they're showing some symptoms that I'm concerned about. I've referred them onto the GP. GP has done an assessment, we've perhaps even organised for a mental health care plan. Have you engaged much with those patients, and how do you find that patients experience that connection as well? And what is their experience?
Yeah, I've come to contact with a few patients that I think, working with LaRue, I'm quite privileged in seeing what they do, which I'm not sure everyone is aware of, but I've worked with a lot of LaRue officers when we have been working with someone who may be suffering with a mental illness that doesn't need to come to hospital. They've really assisted in linking with a GP in the community, using their own tools and ambulance-related resources to get the person further support, such as booking GP appointments or even taking people to a GP. I tend to find that the collaborative relationship between crisis mental health services and the GPs and mental health patients is really important. In my experience, I found a lot of patients, when they go to their GP and the GP is not entirely sure or seeking more assistance, they'll often reach out to us themselves, and the patient will find that quite beneficial, because sometimes those crisis mental health services may be a little better versed in what resources are available, or how to help guide a person navigate the system and find the resources are most important to them. So I would say that majority of the time I've worked with people where they've either come in contact with us from their GP or they've come to us wanting support to see their GP. It's been a positive outcome because we've been able to help navigate the complexity of the mental health system. Sorry, Dave, I couldn't hear you.
Sorry, I thought I hit the button there. We have a question from Paul Ben. So do you have a checklist for discharging patients? This is a pretty, that is probably a whole new topic and point of discussion, but when you're discharging patients, and I would go and put a, maybe a caveat on that to say, when we go out to somebody in the community and you're not taking them to hospital, you're referring them on to another service, that is a sense of discharge as well. So do you have any checklists or systems that you run through to make sure that you're happy? We've discussed risk, but do you have any systems in place there?
I'll talk about this from two perspectives. So the team I work for, the acute care team, is quite broad in what we do. So I'll start by talking about my role just briefly first. So in my role, I'm sort of like an entry point into the service rather than discharge point. But what I would be doing is, if I'm seeing a patient, I've done an assessment, and I'll use the example if I'm leaving someone on scene, there is a checklist in essence. If it's someone who would be suicidal, I'd be looking at doing a safety plan with them. I'd be wanting to engage with some collateral from support where possible and engaging supports around the person. I'll then be referring back to our broader team to have a discussion with our heads of service and our psychiatrists as to whether the plan I've put in place is correct, and organise an appointment for a service within our team to come out and see them again within the next, say, 24 to 72 hours to ensure that that person's crisis is sort of contained and they're sort of being able to link in with further services. Stepping away from my role and talking more about our acute care team, when we are discharging someone from our service, we will try and have a discharge checklist, which will be ensuring that there's a letter sent out to the GP. We've tried to talk to their loved ones or support networks, so patients informed they're being close to our service. But I'm not necessarily a big believer in checklists as such. I think this should all be best practice. I think, if someone's going to be discharged from our service, we want to make sure that we've communicated with their primary care supports what's happening, what our impression is, and sort of saying, you can reach back out to us if you need it. So in essence, we do have a discharge checklist, but I think it should be a standard of practice, regardless of having a proper tick and flick sort of thing.
Great. And just our last question here from Greg. He says that you do work in a tough area, and I agree with that. You do a fantastic job, and you work in a really important space. But what do you think about crisis phone lines? He's used Beyond Blue as an example, and there are a number of others where people can call up if they're in crisis. What is your experience with them, and what do you think the value add is in that in the setting of a mental health crisis?
I think they're fantastic. I think they provide, quite, when I say easy, I mean in the sense of direct contact, in being able to talk to someone when someone's in distress or wanting support or access to share their feelings. My experience is we don't necessarily work closely with, for example, Beyond Blue or Lifeline or the Black Dog Institute or anything like that. But often what we'll get is, if they're in contact with a person who's in distress or who may be suicidal or quite unwell, often these services will reach out to us and say, hey, I've got Joe Blow, he's got a history of depression, his depression's getting worse, he's starting to have suicidal thoughts, are you guys able to help out? So there is some sort of collaboration there when things are needed. I personally think it's great. I would, I think it's important that if you are someone who's struggling, you find it hard to talk, being able to pick up the phone and being able to talk to someone immediately just to share how you're feeling is really important. So I'm very pro these services. They're sort of, a part of this layer that Australia is developing to help people cope with their mental health and those sorts of things.
Well, thank you very much, Ben. Great presentation. I really appreciate you coming on. I'm sure everyone here really appreciates listening to you today. I thought it was really insightful. As everyone knows, we are recording this and it'll be put up onto the ACPP YouTube page shortly. We'll promote that through our social media so you can rewatch this later. Thank you everyone for coming. We really appreciate it. And we look forward to seeing you at the next webinar. Take care.
Thank you, guys.